The first step in diagnosing orthopedic disorders for me is determining the location. And that flies in the face of what a lot of clinicians do. I think a lot of clinicians hyperfocus or only focus on the area where the patient's complaints are. For example, if there's knee pain, focusing only on the knee. I find a lot of disorders are actually away from the site of symptoms, especially those that have disorders in the spine that are mechanical in nature, meaning the spine's not moving well, and therefore symptoms and signs may appear in the hip or the shoulder or the wrist or elbow. So finding the location is my first order of business. Now, there are many different tests I will use in an orthopedic evaluation to help me arrive at where I think the location is. Of course, range of motion, strength, nerve tension, the verbal history, those things will prominently feature in my decision making. Another possible test I will use for some patients is kind of a pre-positioning test, or testing an extremity when I put the spine in a certain position. But here's two examples. If the patient has painful and or weak, let's say resisted shoulder abduction. So the patient's standing, I have them go into shoulder abduction, I place a force going down, and they say it's either weak and painful or just weak or just painful. That would be a sign and a symptom, and that's not normal. We want the patient to be able to hold against that force without any pain and making it a 5 out of 5 strength test. Now, if I'm concerned or I'm curious about a possible relationship with the neck and those signs and symptoms in the shoulder, I can have the patient hold their arm like we did before in just neutral standing and go into some neck retraction. So holding the neck in some retraction. I could even do neck extension if I wanted, although most times I'm just pre-positioning a retraction and then retest that. Now, if it changes, say the weakness is better, the pain is better, or they're gone, that lends some credibility to the idea of investigating a spinal problem creating the patient's shoulder complaints. If it has no effect, it lends less credibility, but it doesn't exclude it, because maybe the patient doesn't need retraction of their cervical spine. Maybe the patient needs right side bending or right rotation or flexion. So it's one of those things that can help you rule in, but it doesn't necessarily rule out spinal involvement. Another example I've used in the past, let's say there's weak ankle dorsiflexion. Ankle dorsiflexion is a myotome, typically of L4, that I'm testing for patients with low back disorders that create signs and symptoms in the lower extremities. Now, in this example, I would probably say that the person doesn't have low back symptoms, because when I do this pre-positioning test, it's because I'm curious about spinal involvement. Spine pain or spine complaints really elevates the idea that the spine is the source, is the location. So for those patients, I may not add this test during the physical exam. But for those who don't have spine pain, where I am curious, let's say they have ankle complaints or shin or calf complaints, and I want to find out, maybe is there more likelihood that this is spine, lumbar spine, or not? And let's say weak ankle dorsiflexion is present. So the patient is sitting, I have the patient bring her ankle up into full dorsiflexion. I apply a force. On the unaffected side, it's 5 out of 5. They can resist me perfectly. On the affected side, I can push that ankle down and it's weak. Maybe I will then have the patient go into extreme upright sitting and retest, or extreme slouch sitting and retest. Again, I'm looking for a change that may be attributable to the low back position. So like almost every other test, there are very few tests that are diagnostic in and of themselves. We have to look at the whole orthopedic picture. That's why I do a pretty long orthopedic evaluation. I argue that it's very hard in the large majority of cases to do a thorough, competent evaluation in 10 minutes. I spend a lot longer with patients to try to get to the root cause. Again, I find a lot of times the location is away from the site of the complaints. The XBOS study a few years ago corroborates that for a large amount of people with isolated extremity joint complaints or extremity complaints, moving the spine in a specific direction restores that extremity complaint to normal. So abolishes the patient's symptoms in the extremity. Therefore, because of studies like that and because of my clinical experience, finding the location is number one, because we have to pin down the location before we can get to what is the diagnosis in that location, what movement, what direction of movement is necessary, and how much force is necessary. Finding that location and using that pre-positioning kind of test in various ways can help us arrive at that location decision.